I'm going to talk about a whole bunch of stuff. I want to talk about education first, kind of on a historical basis of where it's come from. And I want to talk about some of the issues that are currently going on in academic circles around education. And I have a few little exercises for you to do, which will be fun, but I do want your involvement with it. And I'm going to finish with just a little bit of data around reflection on practice and what does it mean in terms of outcomes? Does it make things better? Middle Ages, learning was considered to be higher learning. When I come from Ireland, is anyone else here from Ireland? Good on you. Where are you from? So am I. I'll have a chat at lunchtime. And I learned Latin at school. Did anyone else learn Latin? Yeah. Pretty irrelevant, isn't it? It's just amazing that, even in almost modern day, that people still learn Latin. So education you can talk about in the industrial ages, had very much an industrial process around it. You know, these were units of people coming through, kind of like a factory, to be given information that they would then regurgitate at the correct time, and that was considered to be they had learnt it. Which is very old-fashioned. Then along came this guy Skinner, who talked about behavioralism. This was in about 1970, 1980. But I presume people have sort of come across Skinner. Yeah, which started to look at education being somewhat different. But he used a sort of a change behavior by reward and punishment type process. And again, in my medical training, in my first year at university, we had little lab rats that we had to look at and try and yeah? You had little lab rats? Did you name your lab rat?
No, I didn't name my lab rat. I was too scared to, because then
Yeah, they tend to die rather rapidly, yes. We used to call ours after the lecturers, but... Then after that comes along cognitive theory, and this is starting to get a lot more interesting. So if you have a look at that slide there, here's a kid starting to learn. But if you look at the environment, in a home where this kid is comfortable, with their parent, whom they love and they feel really close to, he's got the apron on, the part of the symbol of doing something. And that's a kid who's having one heck of a lot of fun. And to me, that's one of the key things about education that is so often missed out. Actually, good education is a heap of fun. And so cognitive theory says the beliefs, attitudes, and values and the surrounding milieu in which education happens is really, really important. But you also have this issue here in terms of what is learning. So this is somebody who's produced something of what they consider to be high value, but there's no other process going on for this person to let them know that perhaps they actually didn't hit the mark. And this is, I think, what is so critically important about reflection on practice. And essentially it says is you can have a range of experiences, but that doesn't mean to say that you've actually learned something. And in medicine, we have this, in medical education, we have this thing of experience can be making the same mistake with increasing levels of confidence over an impressive number of years. And that's the problem with traditional education. Without reflection on practice, you get caught in this thing of doing the same thing over and over and over again. This is a paper I published 5 years ago, and I called it, "Oh no, it happened again." Really what it was talking about was medical error. And myself, like every health practitioner everywhere, makes errors. And I called it, "Oh no, it happened again," because I was recognizing patterns of things going wrong. I'm not sure if you can read that first little bit. And it's a true thing that happened and keeps happening. is, in the middle of a busy surgery, and nurse comes along and says, Stephen, Mr. Smith, he's at the front desk. He needs his prescription now because he's going on holiday. He forgot to ring in. And so you say, okay, not a problem. He needs some bendrafluozide, whatever. And you furiously type because you're running slightly late. The next patient's coming in. You know there's an asthmatic coming in a little bit later. And on the computerized system, I don't change from the 3-year-old child I was just seeing to the correct patient. And so I prescribe antihypertensive medications for a 3-year-old child. Now, clearly, that's going to be caught. The pharmacist can find that error and say, oh, Stephen, you've done it again. But that's the problem. These things just keep on happening over and over. And it's only when you stand back a little bit and start to think about what quality is, and start to think about how do I stop things from happening again? And the answer is, well, it's reflection on practice. So, and I know that you've all got little pieces of paper in front of you, and what I want you to do is to write down 1 or 2 things that's happened within the last 2 weeks. I'm not looking for, patient died as a result of my manipulation of their whatever, but just something small that happened that you're thinking, man, that was a bit irritating. I really wish that hadn't happened. So I want you to write something down. You have to. And I want them to be the sorts of things that you can talk about. So if there's some things that you might have done that you don't want to talk about, and with the council members present, but if there is things that you can talk about. So who's going to be really good and put their hand up and tell us what was the one thing that happened that's sort of playing on their mind just a little bit that they did? John.
I pulled out the wrong file and started treating a person who wasn't the person I had in front of me.
And do you know how easy that's to do on an electronic system? Because all GPs use electronic systems. It is so easy to do. And again, you're typing the notes furiously into your electronic system, and you look up and you think, wrong patient. And what's even worse in the GP systems is when you prescribe something, you can't unprescribe it, so it stays in the patient notes forever as a salient reminder of your fallibility. So you picked out the wrong patient notes and you thought, oh, this is somebody with something, and started treating them, and then you realized, right. Who else would like to talk about just something that was irritating that they did wrong? Sorry, your name is?
Phil.
Phil.
I've been seeing a patient for a few weeks for pain in their neck area and had never considered their shoulder, which turned out to be the root cause of the problem.
Right. So you'd got focused in on the neck, and you were ignoring the shoulder. And again, this is a common type of phenomenon that occurs in medicine. Do you know what confirmation bias is? Do you think that that's what was going on? That you were looking at the neck, you became blinkered to other things, you were just looking for more information that confirmed for you that this is the neck, without thinking?
Potentially as it went on, there was nothing in the initial case history to suggest the shoulder was involved, and the initial screens were negative. So at that point I left the shoulder aside.
Right.
But several weeks on, turned out that wasn't the case.
That was the case. Yep. Other things? Is that your hand going up to talk?
Yes, I've got one.
Yeah. I've volunteered you.
Treatment's going really well, running out of time, thinking we need to prescription of stretchers. Forget to show them how to do these stretchers. They leave. I think, damn it, that would have really helped them. Next week it'll be a different picture if I'd managed to actually get those stretchers right for them. and I do that several times in a row for the same patient because I'm not changing what I've done.
Right, because you're not changing what you've done.
Yeah, and that's when I'm,
Yeah.
that's a big fan of
Yeah, and this happens everywhere, you know, and I have to ring up patients and say, hey, we did talk about doing a blood test. I forgot to give you the form. And they're usually pretty good about it. Oh, yeah, no problem. I'll pick up the form, doc. You know, so, yeah, a bit of an oversight like that. Who else would like to share one thing with us? Yeah. Sorry, your name is? Julia. Julia.
The wrong name for quite a phenomenal amount of time.
Yeah.
I mean, you know, you do, they were both there, but it wasn't one of those things I could talk away and say, oh, yes, but this is so related, like, I might go to the neck and shoulder. I really was just, you know.
This is the wrong knee. Let me tell you a story about, I think it's Ascot Hospital, which is a private hospital in Auckland, a really big hospital. It's pretty new. I think it's about 5 years old. And I don't know how many millions of dollars that they spent building this with flash new theatres. Opening day, they had a theatre list with one of their better orthopedic surgeons. The first case was a hip replacement. He did it on the wrong side. Yep. Flash hospital, first day, first list, first patient, wrong side. They happen. Who else would like to share something? Would you care to? Some little thing that happened over the last 2 weeks.
The only thing, I mean, it's not really something that didn't go quite right, but it is something that I'm uncomfortable with, which is a patient that came in last week who is 14 years old and has seemingly very, very quickly developed a rather nasty looking idiopathic scoliosis, and I was quite keen to send for cob angles pretty speedily, but the mum's quite keen to wait till we do the GP next week, and I've spoken with the GP and he'll do the cob angles, and I was uncomfortable with the delays. I think she's in a bit of a pickle.
Right, so you're thinking this actually is acute. This needs investigation now.
I think that they need to assess the state of the angles. Yeah, I think that they need, the sooner that they get cob angles, the better, to get baseline and to start trying to manage the process.
Right. Forgive me, I don't know what a cob angle is.
Oh, when they are doing x-rays to determine the bend of the scoliosis, it's the angles of the curvature, and it gives you an assessment of how that process then might be managed and where we are right now.
Right. Okay. So this is a bit of a process that you can actually use to look at things that haven't gone quite right. What happened? What were you thinking and feeling? What sense can you make of it? What else could you have done? And if the situation arose, what would you do? But of course, one of the things that's kind of neat around reflection is that, in fact, it's actually a lot better off when you actually talk to somebody about it. And, you know, there's a whole bunch of models around reflection. This is just one of them, Kolb's cycle. And, you know, if you look at the top, concrete experience, oh, damn, it happened again, or no, I grabbed the wrong note, or I wasn't listening to myself around just how acute this issue was, or I didn't quite identify the right knee, or the left knee, as it should have probably been. And then it's sort of, you know, that reflective observation. And then this abstract conceptualization is, I understand what went wrong. And now I'm going to do something to make sure it doesn't happen again. So what I want you to do is, I presume you all know each other, do you? Just about? Sort of. To the person next to you, if you don't know them, could you introduce yourself? Good. Good. Just introduce yourselves. person, take one of the things that you're comfortable that went slightly wrong and have a chat with this person and just go through. So, you know, there's going to be one of you is going to be the person who's written the thing down, and the other person is just going to do a little bit of an interview, just to go through that. What happened? What were you thinking and feeling? What sense can you make of it? What else could you have done? And if the situation arose again, how would you do things differently? So just have a chat with the person next to you. Take one of those things off the top of the list. Good, good. Okay, folks. We've got two volunteers here who are just going to talk about what it felt like just to go through a structured process around this reflection. And one of the things that is absolutely crucial to remember, the narrative is the way we make sense out of the things that happen to us. When you talk about things, it takes them from being totally internal into a shared space. So I'm going to get you guys, how did you feel about sort of chatting with a structure like this?
It definitely gave us a, step by step. So you felt like you were being led through it more so than having to come up with all of that on your own straight away. Right.
So the structure was quite nice in terms of, I know what to do. So were you the person asking the questions? You were. So how did it feel to be on the receiving end of those questions when somebody was saying, let me just bring you through this process?
It wasn't invasive. It just made me feel like I could talk about it without feeling judged or that I'd really done something wrong.
Right. And that is one of the absolutely crucial things in giving feedback. If I could just demonstrate. When you're giving, in terms of doing that, do you mind just sitting here? So let's say you're talking about something that's actually quite difficult to talk about. Now, things that go wrong is difficult to talk about. You can do it in a sort of you-type stuff, or you can do this. So this is the issue over here. So this is what you think was going on. Could you tell me about this issue? See that the difference between being alongside somebody to being in front of somebody? It's not so confrontational. So you're objectivizing the thing and allowing somebody to discuss a way through a problem. Thank you. Have a seat.
You're also showing support to that person by being alongside them?
Yes, you are. Yes, you are. John?
That's a bit of a gender thing as well. There's a natural preference in men to sit side by side, one looking, one staring over the horizon. And I think there's a gender preference among women to live face to face.
True, although I was really using that as an analogy of being alongside somebody. So yes, the discussion can still be sort of face to face, but it is objectivizing the problem. It's not attaching the problem to a person. It's objectivizing the problem and allowing just some discussion to occur around that. So you guys, you had a discussion. Just talk about what happened.
The discussion of the problem.
I guess how well you thought it goes in terms of using a structured approach to talking to somebody.
I thought it was really good, and I felt it was nicely challenged too, when Rosemary put me in spots of what I did differently. Because I didn't really have any answers to hand, I sort of had to sit around inside myself and think laterally. Yeah, so it was good, it was a creative process.
Yeah. Do you feel it's kind of different from just writing down something yourself and trying to reflect on it, that you've got somebody?
Absolutely, yeah.
Yeah, that's the key. Your ability to do things yourself is actually quite limited. In terms of educational theory, if we were in a group of psychologists, nurses, anthropologists, etc., everybody would be talking about sociocultural education theory. It's kind of only making its way into medicine slowly. Medicine is such an old, crusty beast. It's really difficult sometimes to make progress. But one of the things that is so critical in sociocultural education theory is it says that learning occurs in a social context. And it just talks about what's termed the zone of proximal development. There is a place that you can get to by your own reading, by your own data analysis, audit on your practice. And you can only go so far. If you want to stretch further than that, you have to interact with somebody else. Usually, and the expression used is somebody who knows more or knows differently. And this is where a colleague sitting beside you becomes so important. Your colleague brings they're not you, they bring a very different perspective. And different perspectives are good. And so sociocultural education theory would say, as we've just found out, what you can do by yourself is limited. What you can do with somebody with you becomes much more. Just a visual of the same thing. And this is one of the things that it stops you from doing. It's so easy to, in your own little world, to start to develop concepts around your own practice that actually don't reflect reality. And in medicine, we talk about lack of insight and the isolated practitioner as being really difficult problems. The isolated practitioner can be a practitioner literally working in the middle of Auckland or isolated geographically at the top of the North Island. But the isolated practitioner is looked at as being kind of problematic in medicine. All doctors have to belong to peer groups. I belong to 2 peer groups. And there's some very good reasons behind it. And peer groups can vary in terms of their effectiveness and what they do, from ones that are highly introspective to ones where people thoroughly enjoy themselves because they were able to drink 2 glasses of Cab Sauv Merlot and talk about the stock market. Well, that's not quite what we want people to do. But peer groups are really important. So what I've done from one of my peer groups is this is the sort of thing this is the topics that were listed by the person who is taking notes. So this is the sort of stuff that we look at. So there was a general talk about rabies because people get vaccinations for rabies, and there's always this question of, do they need the vaccination or not? Older GP and retirement, that's a crucial bit. Time management in consultations, just these general discussions around things. Social relationship problems and the impact of people's social circumstances on their medical care. Unusual diagnosis, patient complaints, patient advocates, people who talk on behalf of patients, and how as general practitioners should we be interacting with these people. Weight loss, politics and health, billing systems, doctors as patients. Doctors make awful patients. Do osteopaths make awful patients for other osteopaths? Yes? Sometimes. This is some other ones. Professionalism. This was a really difficult series of consultations that one of my colleagues had, where a patient of his was diagnosed with a highly aggressive cancer. None of the specialists who were involved in the care could actually figure out where was the primary. So he was dealing with this patient with some of these awful problems. Young patient, family, all the consequences of them having a terminal illness. Really stressful stuff. Not easy. Doctor-patient boundaries, demanding patients, neck lumps. So that's the kind of things that we talk about at general practice peer groups. There's a couple of things that you can do in terms of structure, which I'll put up a little later, which is guiding conversations in peer groups. And there are ways of doing that. But there are also some rules that go with being in a group and discussing things where there is sensitive information. One of the things that I like about my peer groups is that I feel comfortable sitting down in my peer groups and saying, hey, I stuffed up last week. I missed a diagnosis, or I made a mistake. I prescribed the wrong medication. And it is actually a really, really neat thing to do, rather than this sort of, toad sitting on your shoulder of, damn it, why did I do that? Here is your supportive group that can both listen to what has happened, understand the anger and the grief of doing something that didn't work out, and actually helping you through it. It's actually kind of a neat thing to do. But there are some good rules and regulations around how do you make this process safe for other people in a peer group type setting. And really, again, it's what we were talking about earlier. You're sitting alongside somebody to help them explore things. But the group dynamic is actually really neat, because you've got other people who say, yeah, gosh, that happened to me, and this is what I did about it. I reorganized my notes. I made sure that the names on the spines were correct. I have now developed a system of logging the patients in, so to make sure that the notes that I'm looking at are the right ones. I now have a system to make sure that I don't treat the wrong knee. I have a system, etc., etc., etc. And so the group dynamic becomes actually really useful in terms of widening the experience of providing some solutions. And it is also the most incredibly valuable thing in terms of reflecting on your own practice, of thinking, wow, I could really easily do that same thing. There is a gap in my processes and my systems that would allow me to make exactly that same error. I think I'd better go and fix it. So what I want you to do is to use this Pendleton's rules from the perspective of just working in, say, groups of about 4, because you've got about 8 to a table. So could you just get into little groups of 4 and use one of those things that you wrote down right at the beginning as just that introduction to how it feels to go through that Pendleton's rules to discuss something that went wrong. So you've got about 5 minutes to do that. A bing on that. Okay, folks. What we're going to do is just get a little bit of feedback on how the little group sessions went. I'm going to start over here, because this group here seems to have done particularly well. Do you want to just talk about what happened and how it went? If you can, use the microphone so that we can get it all on tape. Yes, you're on. Yep, that's good.
Okay. So we started off with my forgetting to do the stretches exercise, and they led me down the path of what did you do well, which felt awesome for me, because I could recognise what I had done well within that session and not just feel bad about the stuff that I'd forgotten to do or had done badly. That was really grounding for me, and then I felt safer to talk about the stuff that I hadn't done so well, with the idea of what could you do better. And I had 2 or 3 people go, yep, I do fairly similar things, and this is what I've done to help myself not do it again. Maybe that would work for you. So I had one solution on a housekeeping side of things, and then one of the other members of the group said, and when I do forget, this is what I do to rectify the situation, and this is my backup. So not only did I get a solution for the problem, but I got another way to deal with it if I still fell down and forgot to do my housekeeping, which was great.
Right.
So then we carried on, and somebody else had something else that they brought to the table, and we did the same process again, and they got some resolution with ideas of what they could do to help. And it came out that we were feeling good, that we weren't the only ones with that problem. That it makes me feel so much better knowing that you guys have exactly the same issues that you're dealing with, and that was really lovely, quite supportive.
What does it feel like to actually talk about something that went wrong?
Initially, it was hard to admit that I'd done it wrong in the first place. It was real. It's probably the best word to put on it. Like, I had to be real with myself and everybody else in the room, and that's not easy to do with a group of people that you don't know so well. I'm lucky I've got one or two. But it's also very honest. You can't get away from it. You've just got to be honest. And then the backup of, actually, I'm not the only one with that issue, and these are the ways I've dealt with it, was supportive and felt good, rather than just being stuck on feeling bad all the time.
Yep. About 12 years ago, I had to go up to coronary care at Waikato Hospital and stare a patient of mine in the face and said, I did get the diagnosis wrong, didn't I? Yeah, sometimes we do things wrong, and it was fascinating because I was expecting this guy that I'd clearly misdiagnosed his heart attack was going to lay complaints and move out of my practice. He didn't. He stayed. He was a very loyal patient because he knew, wow, I was never going to make that mistake again. But it felt, in a funny sort of way, so good to go up and say, I stuffed up, I'm sorry. Now, this group over here also had some interesting things.
Is it on?
Yep, you're on. So to talk about, did you think overall the process worked?
It was a very helpful process, mainly because other people have experienced the same. It's about a patient sort of putting pressure on me at the end of the treatment to do something else that I hadn't worked on, and I was running out of time. I had another patient in the waiting room, of course, and so we had a discussion about the pressure that patients can put on us and how to cope with that. It was very helpful.
Yeah, there's a thing in general practice that we say, your patients will kill you if you let them. You actually have to put boundaries, and it's so important sometimes to put those boundaries. Do you want to comment about how you felt there?
I thought it was good too. I've suffered from similar things, feeling like occasionally get put on the spot.
Right.
And usually it's more than one thing's gone wrong. There's more than one time pressures come up, or there's something else in the case that your mind's a little bit distracted by, and then someone that says at the last minute, and then you and maybe you do and you shouldn't have.
Yep. Shall we pass the microphone over here?
We found very similar things in terms of the support. That it's good to hear that other people have similar issues. But what we found is that we had a tendency to just scratch the last point of the process to try and actually get a solution to the problem or the problem.
Right.
And so it was quite difficult to stick to the formulaic process as opposed to straight try and solve the case problem.
Yeah, and as I said to this group, all models are wrong, some models are useful. And it's not that every problem that you encounter is going to be, have insight by going through that process. And in fact, peer groups have many roles. Yes, sometimes it is okay, how can things go better? And a lot of the time, it's also that sharing of similar problems. And it's that cathartic effect of talking about things that went wrong. I'm going to move back to over here. If you can, and if you feel comfortable, to actually talk about the case itself, just to ground it in reality, but only if you feel comfortable doing that.
Mine was not really case yesterday, I just happened to be standing where the receptionist usually sits. You know, I was just checking something there, and the receptionist had gone away somewhere. We have several midwives in where I work, and a woman came in who was, to me, obviously pregnant. And anyway, so I said to her, you know, you're here to see the midwife. That was wrong, you know, I mean, she was actually pregnant, sorry. But it reminded me of another situation where I was at a party once, and you know, this woman, I was talking to this woman who was obviously pregnant. And I said, oh, you know, when's your baby due? And anyway, she said, well, actually, I'm not pregnant. What that reminded me of yesterday was that it's so easy to say the wrong thing. I should have said to her, you know, and I'm sure the receptionist would have said that, who are you here to see? It's so easy to, you know, just could have been, you know, I mean, it's easy to say things that turn out really, really bad.
Yeah.
And you end up, you know, getting a complaint or something like that. And because we just recently had a peer group meeting, and you know, about 2 cases that went to that were about complaints that went to the complaints committee, and really they were just breakdowns in communication. With that, really. Yeah. Anyway, so that's it.
Okay. So how did you find the process of, you know, in a group discussing things that went wrong?
With your issue we were discussing.
Well, we just discussed it, you know, I mean, because you get ideas from other people and, you know, and their experiences with similar things. So,
okay. It gives you a sense of collegiality.
It makes, you know, me say, feel better about the issue.
Okay. Yep. Do you want to just pass the microphone over to these people? And again, if you feel comfortable, just talk about the case itself, as again, you know, it's grounding it in reality.
My name is David, I'm still from the Hawke's Bay. Well, my case, our only case, was one management case, really, not the treatment case. And it was where a lady phoned me up last week who had seen a couple of months previously who needed a cortisone. So I don't know whether you guys should put the cortisones really local, of course, but we can. Her husband, she's 47, his husband's 73, and he was taken in for bypass surgery. Come out of bypass surgery, she was manhandling at home and re-injured her shoulder. And she phoned me up on Monday and said, David, I've re-injured my shoulder exactly the same way. I need another cortisone. And I said, okay, I'll organise that. And there is a process, I don't know if you know, you go through the prior approvals. And I said, it'll take a little bit of time, but I'll get on to it straight away. And I haven't got on to it straight away. And so I'm going to have to, she said, she did actually come to me on Thursday, but she sent me a text, actually, she's got my text number. And said, have you got onto it? I said, I'm getting there. Yeah. So I do feel bad about that. I mean, on Monday I'm going to go through the same process again. She may get turned down, in which case she's 2 weeks behind, possibly getting this cortisone. She could have gone to the doctor. We would have to go through the same process, presumably. The time factor may have been better in her favour because it would have gotten a little quicker than I would have done. But I'm feeling a little bit guilty about that. I'm probably going to have to, you know, confess to that.
One of the critical things in healthcare is that whether we like it or not, there's a huge amount of administrative things to do. And yet, how many of us actually build in protected time to do this? Because we look at it and we think, hang on a sec, every hour that I don't spend seeing patients is an hour that I'm working I'm not earning. But at the same time, there's this thing of, if you're not setting aside protected time to deal with these, they keep on slipping backwards and backwards and backwards. And you know, general practice has had to move. You know, if you go back 10 years ago, there was never built-in time for GPs to do the paperwork, and yet there's a couple of hours of paperwork that has to be done, and referrals being made and phone calls being made for every day of practice. And so what you find now is that that time is built into people's timetables so that they have the time and the opportunity, and it's protected time, which is useful. Do you want to pass the microphone back and let these people talk? So again, if you could talk about the case so we can ground it.
Okay, hello, I'm Emil from Warrior. My case was an interesting one in the sense that it wasn't, I thought it wasn't something that I'd done wrong, but I still felt like there was something missing, so I wanted to run it past my colleagues to see whether there was something that I could have done different. Because that was the sort of premonition that I had that maybe it wasn't enough what I'd done. So to get on to the case, what it was suspected and then confirmed C4-5 disc prolapse, but the problem with it was that clinically it didn't have a distinct mode of onset, or especially not in my mind, because other disc prolapses that I have seen have had quite a specific and quite severe sort of physical force that caused them. So in this particular case, the lady came in about a day and a half or so after being away in Melbourne. That landed at 2 a.m. on one of the Jetstar flights, or where the flies in the middle of the night. She was quite tired. She came in with a headache. I worked in a very gentle way for a headache, really, presenting a complaint. And then the next day she had run up the practice set, still very sore, very severe. She came in and saw one of my colleagues, and then I saw her 2 days after that. So the third, the second time when I saw her, she had quite distinct molecular pain and sort of symptoms pointing towards that disc prolapse. The problem then was as well that in 2 weeks' time she was leaving on a 7-week holiday, which involved 3 different cruises in Europe. So she was really panicking, going, "Oh, what are we doing now?" So I was panicking a little bit as well, thinking that we would be able to go. There was too many things to cancel. They were probably going to lose a lot of money, whatever. So then I referred her to a local specialist who managed to see her really quickly, which was really nice of him. We kind of pulled some strings because of a good relationship, good working relationship that we had. Because the thing was to sort of allow her to still be able to go away on her trip. What they ended up doing was, because they're doing intrathecal cortisone injections, but not in the neck, they didn't feel comfortable to do one. So within about, I think, probably 5 or 6 working days, he managed to organise an MRI and another colleague of his to do the intrathecal cortisone injection. So she did get some relief, went away on the trip last Thursday, and is doing a bit better, but she still gets a disc prolapse. So when she comes back, we'll look at where to go from there. So sorry that it went on like this, quite a long description of what happened. So I still think that went all okay in terms of me clinically processing what happened there, but I was still left feeling, that this case was playing on my mind, as if I'd done something wrong. So that's why I wanted to run and ask my colleagues and see what they thought, like what I should do now. Do I write her an email to say, "Hey, how are you getting on?" Even though knowing that how would she be, but she'll still be pretty sore, but hopefully be bearable. And if she could be nursing a disc prolapse, then probably on a cruise ship somewhere in the Med would probably be the best place to be rehabilitated. So they said that yes, I should write her an email, and that possibly I did everything that I could. So so hopefully, I already feel better just by talking about it, and reassurance from them that there wasn't anything else that I was missing. So I think in that context, the peer group would be really good, and that reflective practice would probably be quite beneficial. So I probably wish that I had like a different scenario, maybe something that I've done really wrong.
Well, in fact, I think what you're talking about, that it was preying on your mind, this thing of, did I do something wrong? Did I not do something wrong? How do I make sense of this? That is what we term messy professional practice. It is the reality that we exist in. As I say to patients, the problem is that diseases don't read textbooks. So we're presented with this mass of social issues on top of odd diagnosis, on top of atypical presentations, on top of logistical issues of trying to get tests and procedures done. That's the reality of what we, to use the term, messy professional practice that we have to negotiate our way through. And yes, I've no doubt that sharing those types of things with a group is the sort of thing that will make you feel better about it.
Yes, yeah? I think that's quite a big thing of what we do and what sort of eats at us after clinical practice, almost a bit like that. The Quiet Boys book and stuff, like what the LA police officers were having to deal with. I think everyone that deals with the public has a certain amount of loading that we take home with us. That would, might make it unpleasant at home, or might affect how many patients you're able to see in a week, or things like that, or whether you even have a complete burnout. So is there a term for that? What you said, like a clinical messy sort of overload, like the stuff that you can't shake, that you're up on the mountain somewhere and you still keep thinking about Mrs. So-and-so and
it comes under various guises. I'm going to talk about it a little bit more later. But you also hit on a very interesting term of burnout, and there's some technical definitions that you can attach to burnout. But one of the things that stops people from burning out is that they are able to unload the burden of things that are causing them problems in a particular place that is safe. And it's kind of like, hey, my home's my home. My work's my work, and if I've got some problems, I can go to my peer group. I can sit down and I can chat about some of the things that are bothering me, so that I leave them in my peer group. Yeah, it's kind of a nice thing to do. Do you want to pass on the microphone?
Ross, mine was more of a discussion with a patient about her daughter. So via email, she wanted to discuss, she'd taken her daughter to see a specialist regarding scoliosis, and the specialist had recommended surgery, and she wanted a second opinion. So I sent him the training email discussing different types of scoliosis, what my limitations are, what I look at, and said I'd have to have a look at her to be able to give you a point of view. To which he responded to say he should probably bring her daughter in, but her specialist had said anyone who says they're going to treat this as a charlatan. To which I just thought, I just not even bother responding to that. To which it had been playing on my mind, because I thought actually maybe I should have responded. But I'd actually put anything. It was good to have the discussion because I put anything. I was happy with what I put down in my email to her. Potentially what I should have done is phone and had a conversation about it rather than just doing it by email, because I think it's kind of a big ambiguous form to be discussing such a thing.
How do you feel about it now that you've had the opportunity to discuss it with empathic colleagues?
Good. Justified. I mean, my thing, I suppose, was the fact that I hadn't responded, that I'd been irritated and hadn't responded. And then different opinions on that.
Good. Do you want to just pop the microphone over here?
I had a case where, I'm Philip, by the way, I'm from Auckland here, North Shore. I had a patient who came to see me with a metatarsal fracture that she had 2 weeks previously. As an acupuncturist, I've found that I can help get that information down a lot faster and to speed up the healing process. So, patient, I suggested to her that she could actually get some medication from the doctor, which she did. I don't think how she put up for 2 weeks anyway, because that's the acute stage. She went to the doctor sent her for an X-ray, I suspected that there was a fracture and we talked about it. But I've had a similar fracture myself and sort of internalised that, well, they're not going to do much. It's something that will take time. We discussed it, I think, time, which was around about 5 weeks for a fracture, 5 or 6 weeks for something like that to resolve. When she went to the doctor immediately sent her for an X-ray. And she came back a little bit irate that I hadn't sent her for the X-ray. And I said, well, it would not have changed the treatment that I would have given because that's what we talked about. She said, but I would have managed it better. I would have not tried to walk it off or I would have looked after it better. And so I learned from that experience that you do have to empower the patient and give them options. And by not, you learn more from getting a diagnosis, even if it's a negative one, because it's a diagnosis. And that going through that stage of not taking full responsibility for it, but allowing the patient to have their own say and giving them choices is a better way to go.
Okay. We're going to move along a little bit and perhaps at the end open up to some other cases that people have been talking about. I do want to talk about how potentially you can structure peer groups. So this is the domains that we use in general practice, and each one of them has a definition that goes with it, and yeah, some of the definitions are a little bit, but you know what it does is it focuses around making sure that we're not spending the entire time on management, that we're not spending the entire time talking about difficult communities, that we're spreading the material over in the domains. And similarly, that's for example, a list that has been drawn up. You could quibble about what should be in there or what shouldn't be in there, but what it does is it just makes sure that you're sampling widely, that you're not continually recycling the same issues. And this is, as I said, just one that was drawn up for general practice. And what we do is at each meeting, we tick off where we've covered things, which is kind of just easy to do. And this is a paper I published a few years ago when we had a problem that we had from Hamilton. We had final year medical students spread out right across the region. And some of them were 3 hours drive from Hamilton doing their general practice attachments, which they have to do as 6th year medical students. And so I used to, and it was a requirement that we would all meet once a week and talk about their experiences, what had been going on, how to learn from them, etc. And yet these people were 3 hours drive to get to Hamilton for a 9 o'clock start, finish at 4, 3 hours drive back. That's a long travel. So what I did was use a distance education technique, and I got them all onto a Moodle site. And what they had to do was to put down things that had happened, and then other people had to reflect on what was happening. So somebody would say, hey, I was with my GP and we saw, a 23-year-old with really quite bad hip pain. Unusual to see 23-year-olds with hip pain. And so, at the end of the 15-minute consultation, we actually didn't have a diagnosis. I mean, surely we should have a diagnosis at the end of 15 minutes. So what they chose to reflect on was this. One is that they thoroughly enjoyed it. As I said, medicine can be highly criticized for only recently coming on board with reflection on practice as a way of learning. But one, they enjoyed it, and that's just the qualitative comments that they made. But this was also really interesting. Why did they choose particular topics? And I love that little bit at the bottom. They just kept on resurfacing in your head. Now, as a practitioner, and I'm no different than that, and I'm sure you people are no different than that. There are things that just keep on playing on your mind of, did I do it right? What was going on there? Why do I feel bad about that particular interaction with a patient? All this type of stuff that keeps on going. And so that's what it was. The emotional impact became a really important part of why these students chose to put things up on their Moodle site for their colleagues to critique. The cases that had the most ambiguity, professional practice, as I said, is messy. There is lots of ambiguity. The answer wasn't obvious, or the direction wasn't obvious, that they had the most branches coming off them that you could have gone down. Yeah? This is one of my favourite books on reflection on practice, and it's got, although there's some healthcare topics in there, in fact it's just written about reflection on practice for all practitioners, whether you're a engineer or a tradesperson or whatever. It's reflection on practice, Donald Schoen. And there's that expression of his, the swampy lowlands where situations are confusing messes, incapable of technical solution, and usually involve problems of greatest human concern. And we hear about what you said about that woman with the fracture. It's the human interaction that causes the complexity. That woman that you talked about, trying to get off on her holiday. You don't read in textbooks what to do with somebody with a C45 cervical prolapse who's intending to go to the Mediterranean on a cruise ship. It just doesn't. And look, there's many ways. This reflection on practice is a common theme, and there are many various models that exist. And it's not that one is right and one is wrong. They're kind of different ways of thinking about the whole process. And certainly, Medical Council of New Zealand, this comes from their statements, and you will see that provided by individual learning needs, high standards, and in there, where is it gone? Right at the bottom, good medical practice requires to reflect regularly on your standards of medical practice. And of course, as all of the material that we've put up beforehand and some of the examples that we've had of how limited it is when you're doing it yourself, you're going to reflect on your practice, you need to do it with people. It doesn't happen by yourself, which is why Medical Council says every doctor will be in peer groups and will discuss the issues that are getting them down. Midwives, similarly, examine her practice with colleagues and consumer representatives. I'm going to talk a little bit about some of the outcomes research for those who like evidence and say, what is the evidence basis for us moving forward in terms of our concepts around education? And this one is an interesting one. Appraisal of medical students may result in deeper learning rather than a kind of superficial understanding. They know why they do things rather than just doing them. This one, change their interactions with their peers as a result of reflection on practice. Improvement of clinical practice as the chief benefit from reflection. Integral in planning and anticipation of teaching. Oh, I'm kind of into teaching and stuff. Learners were able to connect theory and practice with the assistance of a facilitator. You need somebody alongside to put the two of them together. And this one is a systematic review, which is kind of like meta-analysis, a whole bunch of stuff brought together to try to make sense of a particular topic. And that is in particular, if you're looking for material to give an evidence basis for reflection on practice, then that's the paper you should have a look at, because I think it's just excellent. And you don't need to write it down, we'll give slides and all that type of stuff. So, What do you think?
Not a lot of soft tissue work.
Yes. What does it feel like as a way forward?
What was the question?
What does this feel like as a way forward?
I'm very new to the profession. I've only been with it for about 6 years, and I feel that's very new. And my mother's a counsellor, and she's been doing these things for...
Yeah.
And I've never understood why we aren't doing it already. It's fabulous. I think it's a really awesome way forward.
Good.
For all of us.
Yeah.
There's a practical question really with the increase of technology and distance issues and you having run reflective stuff on a platform like Moodle. What's the issue with privacy and patient confidentiality and discussing cases in an online platform? Is there any kind of knowledge of what works and what doesn't work?
Yeah, whatever systems or processes that may evolve for you as a professional group, there does have to be some sense of clinical governance that looks at a whole bunch of these issues. So the Moodle one worked well because we had to get formal ethics approval, etc., etc., etc. But we did a couple of other things. So I was the moderator. I read everything that went on, and if somebody was putting stuff that was inappropriate, I'd take it off. For the first meeting, we went through how they were going to use this process and the issues about confidentiality that were so important. But having said that, yes, there's all these areas of confidentiality, it's the messiness of the real world that these final year medical students found so useful to talk about. So this wasn't so much, oh no, there was a few of them. There was one student who was in a very remote rural practice who said, hey, you guys, you have no idea what I've seen in this last week. A double pneumonia, a septicemia, meningococcal meningitis, a fractured femur, and everybody was going, wow. Yeah. In that particular practice. But it wasn't so much that they were talking about specific cases and specific diagnostic criteria. It was this overall messiness that they needed clarification of and that they found it so useful. But yes, there has to be some form of clinical governance to lay down some ground rules about what is and isn't permissible.
Reflection versus supervision. What's the difference with the boundary? Because a good supervisor would go through a very similar process.
Yes, they would. Yes, they would. I guess when we talk about supervision, you can talk about it in many ways, and it has many definitions. So the supervision that, for example, your mum would get as a psychologist is very rigorous, and it has to be. The same with a psychiatrist, is very rigorous supervision, looking at transference and countertransference, how you're taking on board the issues of the patient, how the patient is responding to the issues that you bring. And now that becomes really quite psychoanalytical. Whereas peer groups, my general practice peer groups, this is a bunch of colleagues sitting down, being supportive to each other. So that's quite different. There's also potentially implications in terms of supervision of, is this a paid relationship? Should we be paying the supervisor to provide supervision? So it does have a different feel. I would agree that some of those processes are probably very similar, but supervision overall probably is more useful for when there are some significant issues rather than keeping everybody on the straight and narrow and feeling comfortable and safe in their work is the way that I would look at that.
Do you find there's any difference coming in the today's world when the previous, back 10, 15 years ago, when all your peer groups and all that were face-to-face, and the new world is going to be video conferencing and non-technically non-face-to-face?
There are some issues with that. So, with the University of Auckland, I'm on the Board of Studies and the Board of Examiners and the curriculum development groups. And I live in Hamilton. Now, that's the problem. It's 2.5 hours to get to the medical school at Auckland, and probably 2 hours back. So we use Zoom. Did anyone else use Zoom? Oh, man, it's good. Oh, it beats the socks off Skype. Sorry, I'm a technical person as well. But there's a problem with Zooming in that there are a bunch of peripheral conversations that happen at meetings that actually are really important. They're really important in terms of the interpersonal relationships that you build. Zoom and Skype and teleconferencing and video conferencing, you don't get those nice fuzzy bits around the edge.
Do you think that's going to change with the upcoming generation?
I don't know.
The places are basically IT work and it's all done on small screen.
Yeah.
And they're quite comfortable with that and they have a different parameters of usage to what we do. Do you think this is going to change this?
I have the feeling not. I have the feeling that the interpersonal stuff that happens, you can't get away from that. You may be able to substitute some. So with this paper, yes, we all met as a group at the beginning. We all met as a group at the end. And in between times, we used Moodle, and I would Skype them once a week for an hour to figure out how they were doing and give them some support and stuff. It may take some of it, but it's not going to take all. Just that thing of sitting down over a cup of coffee with some people that you trust and being in that environment.
There's an interesting statement in the Standard paper. There's a good article that they were saying that the average person has 5 close friends, and this has come from as far back as they can count.
Has 5
close friends,
right,
that they trust and they relate to, but they may have many associates. So what we're talking about here is associates, not friends.
That's correct.
Would the same discussion occur between friends as occurs between associates and where you draw the line?
Because peer groups.
Also trying putting in these associates to be the IT type associates with a non-physical
Yeah. I think it is that these are associates who have a particular purpose in your life, and you have a particular set of, not rules, but ways of interacting, things that make the interaction safe. So the purpose is to maintain good practice and to make yourself feel better about what you're doing. We've heard of people in this room who said, "Oh, I feel a bit better now." So that's the purpose, and there are things that shape those conversations, like those processes that you worked your way through. So that's what to me would be different, and there's an understanding between people around confidentiality and that it's going to be a safe place, etc., etc.
I think also the stuff that you did at the beginning of putting yourself aside as opposed to opposite, that you can't. And that brings a lot to the dynamic. You can't do any of that with you into square box, which is great, but it's different. It's not the same as it's very controlling. Very controlling. What are we doing as have that person next door to you? I mean, I think from a council's, I could just shout. From the council's perspective, the council's CPD process that everybody has to do, historically, it's in the process of change, but historically it's been very much you have to tick the box on a number of hours of sitting in the back of the conference and, emailing your mate. As long as you get your attendance certificate, it's all the things that really don't actually have a relationship to competency particularly. And so the council is really looking at that, trying to move things into the direction of, what are the things that we actually do as practitioners that have a direct relationship to our competency and our Monday morning. And it isn't so much the conferences, and it is much more located around some of those interpersonal things and some of that informality.
I absolutely agree with you. There's a talk I give to various groups that's taken off like wildfire, which is around evidence-based education. So looking at, and wow, we have now got good evidence as to what works. And so I divide things in between. Here is evidence that this makes a substantial difference to either the performance of the health practitioner or patient outcomes, because those are the only two that actually matter. Whether you enjoyed the education event is irrelevant. Whether you actually learnt something is kind of actually irrelevant. It's, did it make any difference to how you practice, and did it make any difference to patient outcomes? And I divide them in between. There are initiatives where we know that there is strong evidence. There are some initiatives where it is apparent that it has moderate, and there are initiatives such as going to conferences where the data is absolutely clear. It makes no difference to the behavior of the health practitioner, and it makes no difference to patient outcomes. Now that's on a population basis, and an individual could come along and say, I learned that piece of information at a conference and therefore I know that. So we're talking about population-based focus. But if we're talked at the beginning around the direction that education is going, the next wave, evidence-based education. And yes, reflection on practice is evidence-based. My time is up.